Dear colleagues, it's a real pleasure and a privilege to present the 2018 EACTS Guidelines on myocardial revascularization for the first time. These are my conflicts of interest. On behalf of the task force, Miguel Sousa Uva and I are honored to highlight some important points. Let's first look at procedural aspects of PCI. What's new? We recommend radial access as the standard approach irrespective of the patient presentation, and we also recommend drug-eluting stents for any PCI irrespective of the intended duration of dual antiplatelet therapy. We also upgraded provisional T stenting for bifurcation lesions from class 2A to class 1 and OCT for stent optimization from class 2B to class 2A. As an exception to the rule of provisional T stenting, we mentioned double kissing crush technique in true left main bifurcation lesions with a class 2B recommendation. We also discourage routine revascularization of non-culprit lesions during primary PCI and myocardial infarction with cardiogenic shock based on the culprit shock trial and current generation bioresorbable scaffolds for clinical use outside clinical studies, but this should not impede the development of this technology. We also downgraded distal protection for saphenous vein graft lesions, but it still maintains a class 2A recommendation. For peri and post-interventional antithrombotic treatment for PCI, we largely follow the 2017 update for dual antiplatelet therapy. There are also some new recommendations. There is a class 2A recommendation that NOACs should be preferred over vitamin K antagonists in patients with non-valvular atrial fibrillation requiring anticoagulation and antiplatelet treatment. And if the choice is the bigatran, the 150 milligram dose may be preferred over the 110 milligram dose when combined with a single antiplatelet therapy. We also mentioned for the first time with the class 2B recommendation Cangrelor in P2Y12 inhibitor naive patients undergoing PCI, and there is a similar recommendation for GP2B3A inhibitors in the setting of acute coronary syndromes. We also mentioned for the first time with the class 2B recommendation de-escalation of P2Y12 inhibitor therapy after an acute coronary syndrome guided by platelet function testing. There were no upgrades, but we downgraded bivalirudin for patients with acute coronary syndromes, mainly based on the Validate Sweetheart trial. Now, what are the indications for myocardial revascularization? We still acknowledge a symptomatic indication with insufficient response to optimized medical therapy, but we specify that this should take into account patient compliance and wishes in relation to intensity of anti-anginal therapy. There are also prognostic indications with stable angina, and as previously, these are left main disease, proximal LAD stenosis, and 2 or 3 vessel disease with impaired left ventricular function. But we specify that this needs documented ischemia or documentation of hemodynamically relevant lesions defined by the conventional thresholds of FFR or IFR, unless there is a major stenosis in a major coronary vessel. In addition, a large area of ischemia detected by functional testing or by a substantially abnormal FFR is an indication for revascularization even of a single coronary lesion, but for this the threshold of FFR is lower below 0.75 as indicated by a large meta-analysis. This impacts on functional testing. When evidence of ischemia is not available, FFR or IFR are recommended. There are also class 2A recommendations for FFR guidance in multivessel PCI and for IVUS guidance to assess the severity of unprotected left main lesions. Now, when it comes to the choice between PCI and CABG, what are criteria? For major criteria, the task force could build on a recent individual patient data meta-analysis of all randomized trials looking at PCI or CABG in multivessel disease or left main disease. Overall, 5-year survival was significantly better after CABG than after PCI. This survival benefit was larger and more pronounced in the multivessel subset, and in the left main subset it was less pronounced and statistically insignificant. The complexity of coronary artery disease assessed by the syntax score is also a significant modifier of treatment effect. With low syntax score, survival is consistently similar between CABG and PCI, whereas with high syntax scores, there is a substantial benefit of CABG. Again, the dependence on the complexity is more pronounced with multivessel disease than with left main disease. Diabetes is also associated with a larger benefit of CABG, with significant interaction p-values in the entire cohort and in multivessel disease. We also need to consider surgical risk, and for this we recommend STS score with a class 1 recommendation and Euroscore 2 with a class 2B recommendation. Syntax score, as said, has a class 1 recommendation, and in addition, completeness of revascularization should be prioritized when deciding between CABG and PCI. Now, what are then the choices between CABG and PCI in stable coronary artery disease? With one vessel and two vessel disease, both CABG and PCI are an option, with a preference for PCI in the absence of a proximal LAD stenosis. For left main disease, CABG is always an option with a class 1A recommendation. For PCI, given the incomplete 5-year follow-up of EACTS and NOBLE and the imprecise risk estimates for the high syntax scores, the task force decided to take a cautious position and maintain the previous recommendations. That is, class 1 for PCI in left main with low syntax score, class 2A for intermediate syntax score, and class 3 for high syntax scores. But we state that PCI should be considered if the patient refuses CABG after adequate counseling by the heart team. Now, this concludes the first part of our presentation, and I'm happy to hand over to Miguel.